Hello to all. How are you? I hope you have a good weekend. Now, this is the last seminar that it's about preterm labor. This seminar is going to be only online version because I will be on vacations during this week. I will not be in the hospital. So you only can study with this video and the notes. This topic is very important, it's preterm labor. It's a very common cause of neonatal morbidity and mortality. So it's very important to pay attention because the treatment is very effective and you can prevent all the complications of a preterm baby with a correct management of these patients. And this patient must be managed in a good way in a few seconds, in a few minutes with this patient, you have to take the decision to give a treatment that can change the prognosis of the patient. So it's important to know this treatment. We're going to check in this class the definition of preterm labor, how to diagnose that, why it's so important to know about this topic, the risk factor to have a preterm labor, also what to do with a preterm labor patients, the general approach, how to approach these patients, and how we can diagnose and classify, how to manage and how to prevent this disease, this complication, and in the situation that we are in front of this, that is very common, so we will be, how to deliver this patient. I want to thank Catalina Bustos, that is a nurse from Chile. She also helped me to prepare this presentation, and he helped me a lot with this part also, how to deliver a baby. So the definition of a preterm labor is very easy. It's the onset of labor when the fetus has not reached the adequate gestational age. So it's when the labor starts before the normal and the baby is not prepared to live out the uterus. How we can diagnose this? It's also it's very easy. We need to have preterm pregnancy, so a pregnancy before 37 weeks, and labor, symptoms of labor, and physical examination compatible with labor. So we are going to talk about a little about that. We can classify the preterm labor in late preterm, that is 32 to 37 weeks. It doesn't have too much complications, only minor complications, and most of the baby are okay. Very preterm, that is between 28 and 32, that increase a little bit the mortality, and extremely preterm, that is under 28. These babies have a lot of mortality and it's very difficult to manage them. But this group is very important for us because this is the group that most benefit from the treatment, that is corticoids, and we're going to talk about that soon. So preterm labor diagnosis, we know that we need the diagnosis of labor and prematurity. So the labor we diagnose, as I said to you in the other seminar, with uterine dynamic, so uterine contractions, and cervical modification. Those two things make us to make the diagnosis of labor. Now, if this mother is term, it's a normal labor. If this mother is preterm, it's a preterm labor, that is a complication, a disease that we need to treat and prevent. How we can diagnose the gestational age? With a physical examination, that is measuring the fundal height. We can do it with fingers or with centimeters. With centimeters is more accurate, but here in Bagari, all the people do it with fingers, and it's very fast, and it's also very easy to do. And the key message here is that we need to believe this, because it's very accurate, and we can have an idea. If there is a mother that doesn't have antenatal care and we don't know anything about the mother, it's very useful to have an idea about the duration of the pregnancy. But also in some pathologies, for example, macrosomy or uterine growing restriction, we can have fake gestational ages. So it's important to have that in mind. The most accurate and the best way to have the gestational age, as I said to you in previous seminars, is the LMP, but must be safe and trustworthy, and most of the time it's not possible with our patient to have like a LMP that we can trust. That's why sometimes we have to believe our hands if we're in an emergency. If we have time, we can ask for an ultrasound. But in the emergencies, we don't have time for that. For example, a preterm labor that is on 4 centimeters, we don't have time. So we need to believe our physical exam. And with the ultrasound, it's also accurate, but happen the same than with the physical exam. If we make it very late in the pregnancy, at the 35 weeks, if the mother have a pathology during the pregnancy, like diabetes or intrauterine growth restriction, it won't be accurate, the gestational age. Okay, so with our physical examination, our clinical history is enough to diagnose the onset of labor. Okay, we don't need other tests. And why is important to be able to diagnose this? Why is important this topic? This is not because of the mother. For the mother, there's no complication. But here, we want to save the baby. So it's very important because it's very frequent. The incidence is 11% globally and have a lot of neonatal morbidity and mortality. Here in Kenya is the principal cause of neonatal morbidity and mortality. Okay, 75% of the perinatal deaths are due to prematurity. So we can say that this is the most important pathology and the most common pathology for the babies in Kenya. As for the mothers, we know that is PPH, postpartum hemorrhage. Is the most common cause of maternal mortality. Well, for neonatal mortality, the most common cause is preterm delivery. So we need to manage those topics very good because it's going to be very common for us to see these patients, and to make a good treatment, we can save life. And not one life in 1 year, no, a lot of life, all the days. So it's very important to manage very good these topics. It's the first cause of admission to NBU and have acute complications, okay? Because here in the picture we see chronic and long-term complications, but also have acute complications in every part of the baby. So it can happen everything for the baby. Risk factors. Well, we have a lot of different risk factors that increase the risk of preterm delivery. We can separate it in maternal risk factor, fetal risk factor, placental risk factor, and in my back is uterine risk factor. So the maternal risk factor is, for example, the maternal age, under 20 or over 40 years. Also low socioeconomic level or previous preterm birth. That is the most important risk factor, to have a previous preterm birth. Also the intergenic period between the last pregnancy and the actual pregnancy, less than 6 months, also increase the risk of preterm labor. Tabacism, to smoke, increase the risk. Single mother that doesn't have a couple. Bad prenatal control or antenatal control. Stress, excessive physical activity, it's also increases the risk. For example, a mother that works a lot also increases the risk. And systemic or genital infection. So any infection systemic can start a preterm labor, and also genital infection that go ascending can also increase the risk of preterm labor. In the fetal factors, well, it's very obvious, but for example, multiple pregnancy, because the uterus grow bigger, macrosomy, fetal death also, congenital anomalies. The placental risk factors, the principal is abruptio placenta and pre-occlusive placenta. Also polyhydramnios, by any cause. And the uterine risk factors, something strange, inside the uterus, for example, a Cooper T. If we have a Cooper T here, and the mother gets pregnant, that increases the risk of preterm labor. Cervical incompetence, short necks, myomas, uterine distension, uterine malformations. Okay, so we have a lot of different risk factors that increase. Also, preeclampsia is a risk factor. So, if someone asks you which is the risk factor for a mother to have a preterm baby, I think all of the things can be a risk factor. Also, psychologically speaking, it's a risk factor for the mother. The causes of the preterm labor, we can divide it in 3 big groups of causes. And each cause is like 1/3 of the causes. So it's like the same ponderation, 1/3, 1/3, 1/3. So the first third is PPROM. The PPROM, that can be by any cause, by a trauma, by an infection, have a different cause, by itself increase the risk of preterm labor. because the rupture of the membrane increased the prostaglandin activation and the membranodecidual activation. So start the process of labor before the correct time. There is also a group, a very important group, 1/3 of the patient, that is idiopathic. So we don't know the cause. It's multigenic cause, but that is why the important risk to have a preterm baby, the most important risk factor is to have a previous preterm baby. Also, because of fetal or maternal pathology that make to us as professionals induce the labor. So this is not a preterm labor that starts by itself. It's a preterm labor that starts because we induce the preterm labor secondary to another cause, secondary to another disease. The most common example is the preeclampsia with severe features. We need to finish the pregnancy if we have a HELP, for example, because the responsible of this disease is the placenta. And to save the life of the mother, we need to take away the placenta, so we induce a preterm labor. So now we have seen how to diagnose preterm labor, why it's important to know about preterm labor, the impact, and the risk factors and causes of the preterm labor. Now we're going to see how to approach this patient, like a practical approach when we are in the Bagari hospital, we're on call, and we are in front of this patient. So how to approach this patient? As I told you in all the seminars, we have this systematical approach pyramid that we need to do with all our patients. So, as always, we start with a complete clinical history. That is the first part. The second, a complete physical examination. That is the second part. With both of these, we can have the diagnosis, most of the important part of the diagnosis, so we can start the treatment. But also, while we continue doing the treatment, we can ask for further tests. But the importance here is that the treatment, we cannot wait until the other test to start the treatment, because the treatment is, the effectivity of the treatment is time dependent. We need hours that we have to make these corticoids make the effect. We're going to talk about that later. And ask for the necessary test, that is the third part, to have an accurate diagnosis. But all of this approach, we need to do it thinking in the causes of this preterm labor and thinking what is happening here with this mother, against what we are. So in the clinical history, we need to ask about the ANC visits, about the previous history in the ANC. So we need to know if she have a controlled pregnancy or not. That we can assess looking how many visits does the mother have. If the mother have more than 3 visits, that means she is responsible. Urine exams. If the mother have the urine exams, because the asymptomatic bacteriuria is one risk factor very important of this patient. Early ultrasound, also very important to have an accurate diagnosis of the gestational age. The LMP, safe and trustworthy, and concordance with this LMP with the gestation by date and gestation by scan. So we need to ask also if the mother have a previous scan. Also about the present complaint, it's very important to ask about this. With this we have the 50% of all the information. We ask about bleeding, discharge, maybe the mother have expelled the mucus plug, that is a sign, a smell of the discharge to look about chorioamnionitis or some genital infection, fever also, uterine contractions to assess if really the mother is in labor or not, to count the number of uterine contractions, when did the uterine contractions started, drainage of liquor, characterize the low abdominal pain. We need to know if it's increasing in frequency and intensity, and if it's radiating to the back or not. All that features can guide us to have a better diagnosis, and also to assess the fetal well-being, to check the fetal movement perception, and also ask about all the risk factors that can help to us. For example, if the mother have a twin pregnancy, of course, increase the risk, or if the mother have a previous preterm labor or macrosomy, intense exercise or exercise during the job or sports, and also urinary tract infections. The physical examination, it's the second part, the second chapter of this systematical approach. And here we need to focus on the general exam first, checking the ABC. Of course, the mother, I think, will be very good. General neurological status, only to rule out other things, because the mother maybe can be consulting because of preeclampsia or something. It's important to always start with the general examination. Emphasis on the temperature, the heart rate, because those two are signs of chorioamnionitis. Also, per abdomen, to check the fundal height and to compare with the gestation by date, the gestation by scan. Some of the times we need to believe the fundal height because the LMP, the mother, doesn't remember well, or she said that she remembered well, but really she have a mistake. So the fundal height here can guide us a lot. And if the mother say that the gestation by date shows, for example, 37 weeks, but by fundal height you check and it's 32 weeks, you don't have to take the risk to believe the mother. You give the treatment as it is a preterm baby. Leopold, to verify the position, the presentation, also important to decide the route of the delivery, uterine dynamic, frequency, intensity, duration. Here I want to make a stop. The uterine dynamic is very important and is in the physical examination is very non-assessed. It's very common that the people in the ward in this hospital doesn't check the uterine dynamic, and it's very easy, but you need patience and time, because you have to put your hand in the belly of the mother during 10 minutes. So in that 10 minutes you count the number of contractions. With that you have the frequency. When you count the contractions, also you count how many seconds did the contractions last, that is the duration, and also the intensity, that is a subjective measurement that you need to assess. With that, you also check between contractions if there is uterine tenderness, and checking the fetal heart rate also to ensure that the baby is alive. Because one cause of preterm labor is fetal demise. And for last, the genital evaluation. Always you have to start with a speculoscopy, because the VE increases the risk of infection. So if with the speculoscopy we have enough information, and we don't need the VE, we think that we don't need the VE, we don't have to do it. The VE, the decision to make a VE, you take it in the moment depending on the situation. Because if the mother is complaining because of low abdominal pain, but she's not with contractions, you don't do the VE. But if you think the mother is really in labor, and you do the speculoscopy and you check that it's bulging membranes, or the mother is with a lot of contractions, of course you have to do the VE to check how far the mother is and to confirm that the mother is in labor. Because you cannot measure the dilatation with the speculoscopy. You only can measure it with your fingers. And for last, the fuel hemogram to check systemic signs of systemic inflammation. The urinalysis to rule out UTI. Also, in places that we have a lot of malaria, it's important to ask for an MPS. And the ultrasound to estimate the fetal weight, the amniotic fluid index, and very important, the gestational age. And in Bagadi we don't have, but it's very important in these situations to have a cervicometry, like the measurement of the length of the cervix with the ultrasound. But that must be with the vaginal ultrasound that we don't have in our facilities. And group and cross-match in the situation that the mother have a complication and we need to do a cesarean section, for example. It's good to have already those exams done. So after the systemic approach of this mother, we have like an idea of what is our mother crossing for. And now we need to think about it and classify this mother in the specific diagnosis, because inside the diagnosis of preterm labor we have a broad spectrum of different severity of the preterm labor diagnosis, of the different stage of evolution, and with these stages we can make our personalized treatment. So now we're going to classify this in 3 different stages: premature labor symptoms, premature labor threatened, and true premature labor. The premature labor symptoms, it's only to have the symptoms. So there's no uterine contractions palpated, closed posterior long cervix in the speculoscopy, so you don't need to make a BE, and rest of the physical exam normal. So the mother only complained of pain, but there is no contractions. That is the key. No contractions when you palpate per abdomen. Premature labor threatened is when we have contractions that we can measure like 6 or more uterine contractions in 10 minutes. And in addition, we have cervical modifications, but only a little. So 50% of effacement or 1 centimeter of dilatation. One of those two is enough to diagnose premature labor threatened. These are the patients that most have a benefit with the tocolysis. And the third stage is when this is more advanced and we have a true premature labor. So this, we have the same quantity, the same amount of contraction, and 100% effacement or more than 3 centimeters of dilatation. So this is near to the active phase of labor. And here the tocolysis is not enough to stop the labor in most of the times, but we can do it. So here this photo is only to show you one part of my country in Chile that is called Mocha Island. This island have sources of natural gas that come from under the water and arise in the water, and you can light fire up the water. As you see here, there is fire, so it's fire arising from the water. It's very interesting and it's a very beautiful place. Well, so now we have seen how to diagnose, why it's important, the risk factors, and the approach for these patients. And we're going to talk about the most important part of the presentation, in my opinion, that is how to prevent and how to manage this pathology in order to save these newborns. So now that we have seen how to diagnose, we're going to check now the most important thing, that is how to manage preterm labor. So the first, if we have anything of this positive, like the exam for malaria, if we are in an endemic zone, or the patient have traveled, or UTI positive, we have to treat it if we have the positive tests. In addition, we need to take the decision if we are going to stop this labor, give medication to stop this labor or not. So in these situations, I'm going to talk about when we need to lead the mother to deliver. The mother must deliver without giving medicine to stop the labor if there are more than 34 weeks with PPROM, with any sign of chorioamnionitis. If there is labor advanced that it cannot be stopped if it's more than 4 centimeters, no matter gestational age, it's a contraindication for the tocolysis. Also, if the mother's life is in a threatened or in danger, no matter gestational age, we need to finish the pregnancy. And if fetal death is confirmed, because we don't have to spend time in trying to save this baby that is already died, sadly. So in this situation that we let the mother deliver, we need to relax. So I should relax myself and don't do nothing, or I have to do something. What do you think? Please put in pause the video and think, what do you have to do if the mother have one of these conditions and is going to deliver? You have to prepare something, or you only let this go on? So the real answer of this is no. And why no? Because we have to prepare the materials and the team for the resuscitation. We need to call someone for the MBU to help us. The MBU team. We need a strictly monitorization of the labor, and there are also special complications that we need to prevent, like the breech delivery, because the baby usually turns the head down after the weeks 32, 34. So in that moment, they increase the risk of having a breech delivery, and with that also increase the risk of asphyxia, cord prolapse, a lot of different things. So the answer is no. We don't have to relax. We need to prepare everything to receive this baby and also prevent the complications that can occur. So here is the most important part of the presentation, in my opinion, that it's about the steroids. dexamethasone in our situation. In other hospital, you use betamethasone. It doesn't matter which corticoid it's. The importance here is to give the 48, hours of corticoids, because this has been demonstrated that helped the baby a lot, and we will see how this helped the baby in a few slides more. So how to manage the preterm labor? Try to stop the contraction first, if the mother have the indication of that. Bed rest, tocolytics, and treatment of the cause if it's detected. Antibiotics, for example. Also, induce the fetal lung maturation. That is the most important. That is the maturation with intramuscular steroids to the mother during 48 hours. Okay? Why is so important the steroids? Because dexamethasone induce the lung maturation, start the secretion of surfactant in the pneumocytes type 2 of the baby, and that in shortly, only to show you the importance, decrease the risk of necrotizing enterocolitis. That is a very common pathology in the premature babies. Decrease the risk of intracerebral hemorrhage, also a very common pathology in the preterm babies. Decrease the risk of respiratory distress. That is very common, yelling membrane in the babies. And the summary of this, and the most important outcome, is that decrease the mortality of our babies and the morbidity of these babies. And this is not like a few effect, it's a very huge effect. Have a considerable change between a baby that have given corticoids and the baby that doesn't receive corticoids. So that is the importance here. But this must be during the 48 hours that I say to you. If we give it only 6 hours, it doesn't have this effect. That's why we need to make also the tocolysis. Tocolysis means to stop the labor. Okay? And the utility of the tocolysis is only to buy time, 48 hours, for the corticoids to act, not more than that. Okay. Also, all the tocolysis or the different drugs that we can use, the maximum effect is only 48 hours, because the labor is something that we cannot stop completely. We only can make it slow, but it's inevitable the birth of this baby. So we only can stop it during 48 hours, no more than that. Here in Bagari Hospital, the drug that we use commonly for tocolysis is nifedipine. We give 20 milligrams per oral. It's the same drug that we use for the management of the high blood pressure in the preeclampsia mother. So it's important to know that a common adverse reaction of this drug is hypotension, and also a contraindication to continue giving it. So that is why if we give it, we also can help this mother giving a little of normal saline that increase the volemia, so we don't have that bad outcome. The scheme to give it this, we have an initial dose that is 20 milligrams every 30 minutes or every 20 minutes, sometimes every 20 minutes, until the stop of the contractions. But this is maximum 3 doses, and if you have any complication, for example hypotension or something, during this administration, we have to stop giving it. And then after that, the maintained dose, that is with this, 20 milligrams BD during only 2 days. That is the days that the corticoids are acting in this baby. Other drugs that are common used in my country, in Chile, phenoterol, also indomethacin, that is very effective, but we only can use it before the 32 weeks, because after the 32 weeks it have complications for the baby in order to close the ductus arteriosus. And atosiban, that is the most expensive drug, but the most non-harmful drug. It doesn't have an adverse reaction. Well, so the tocolysis, in a summary, we give it with nifedipine in our hospital, and it's only to buy time for the corticoids to act only 48 hours. So the tocolysis, in summary, if we take all the mothers that have preterm labor, the tocolysis can be given only to a few of them. That is going to be a group like of 20% of all the mothers. Why? Because it have a lot of contraindications, and the indications are only for a few selected group of mothers. So which are the contraindications? Hypotension, heart failure. Also, if you are mixing with magnesium sulfate, you need to be aware of that, because the magnesium sulfate also decreases the blood pressure, also is a thrombolytic, so it can potence together. And the indications must be the membranes intact. So another contraindication is to have a preterm. There must be no maternal infection. So if we have any sign of maternal infection, we also cannot give the tocolysis. Must be no hemorrhage. Must be a live fetus and a stable condition of the mother. And if the cervical dilatation is under 6, some other people say under 4, we cannot give the tocolysis because that labor is already started and is in the active phase, so it's inevitable. And the tocolysis is only harmful and doesn't have any benefit. Preterm labor prevention. So now that we know how to treat in the moment this patient when are coming for the labor ward with this problem, we're going to see what we can do before this to happen in order to prevent, like primary prevention. So reduce the risk factors. Say to the mothers that cannot smoke. Say to our mothers that doesn't have to carry a lot of weight. If they have a hard job, they have to try to ask for permission or change the charge in the job only during the pregnancy. Do not carry excessive weight. Correct feeding, because the bad nutrition is also a risk factor, or the overnutrition, it's also a risk factor. Adherence to the prenatal checkup or the antenatal care, also very, very important. The treatment of the UTIs or the candidiasis, the genital infections, and also to have ultrasounds to know good the gestational age. Preterm labor prevention specific, we have 3 important things that we can use in order to prevent that. We're not going to specify the indications and when to do it, because this is important to know for the consultant. But we have the vaginal circlage, that is to put a stitch in the cervix in order to maintain that closed, and we decrease the risk of preterm labor. This is indicated in some situations that the consultant determines that have mothers with history of cervical incompetence, that the cervix is not well closed, and without contractions the cervix starts dilating, the dilatation. So a circlage is useful in that situations, but are very specific situations. It's important to know that if a mother have the circlage and come to the labor ward in labor, you need to take away the circlage with a scissor, cutting the stitch. Progesterone is another intervention that we can use, giving 200 micrograms of micronized progesterone intravaginal every day for the short cervix mothers in order to prevent the preterm labor. It's also very expensive and it's not very useful, but it's something that the consultants sometimes indicate. Another thing is the pessaries, that it's a device that you put inside the vagina that also can help. But we're not going to specify more about this. So now the route that we have seen how to diagnose, why it's important, the risk factors, what to do when we have a preterm labor patient, how to prevent it, and the last part is the delivery of a preterm baby. So how should we attend this delivery of a preterm baby? We know, of course, we have talked about that we need to have the resuscitation team, and here the risk is for the fetus, not for the mother. But also, it's important to know how to attend this delivery. So, delivery of a preterm baby. Listen the fetal beats each 30 minutes with a pinner or Doppler. So the monitorization must be more near than a normal labor, because the risk of asphyxia is bigger. Reduce the amount of vaginal examination in order to reduce the neonatal sepsis. Maintain intact membranes the most as possible, because when you broke the membranes, you increase the risk of fetal-maternal infection. So we maintain intact. But if we have doubts about the fetal heart rate and we need to diagnose something to check if there is meconium or not, it's good to break the membrane. Advice to the MBU, have everything prepared, as I said to you. Attend the delivery with a sterile technique, like all the deliveries, but here you need to be very emphatic. Cut the umbilical cord immediately, don't wait, and calculate the Apgar score, of course, not stimulate, and if the baby needs stimulation, just give on the feet, because you can harm the baby. These babies are very fragile. The aspiration is something that all the people use, like this fetus is preterm, we need to aspirate, or here is meconium, we need to aspirate. But it's only if the baby doesn't have a ventilatory effort and you need to clear the secretion, if you hear wet secretion or something. But if the baby is crying and fine, you don't need to aspirate, and only aspirate in the oral cavity and the nose, but not deep suction, because it's also very traumatic. Put oxygen mask in case of need. Dry carefully, wrap the body in a plastic bag, because these babies have a very tiny skin, very, very tiny, and they lost a lot of temperature. So with the body plastic, you try to prevent this loss of electrolytes and loss of water through the skin. Put on a hat to avoid heat loss, and refer the baby to the MBU, and the baby must be in an incubation, in that machine that gives heat, and then the MBU team will take care of the baby, and we have to forget the baby. Corroborate the gestational age with the Ballard test. It's also very important. So the Ballard test, we will talk about that soon. So now we have talked about all the things, the important things of preterm labor. We know that there are a lot of specific things like the pesarium, like the cerclage, but the medular here, the most important thing here is to prevent it in the antenatal care. Try to fight against all the risk factors, and if we have the situation of a preterm labor that can occur, give the corticoids and try to buy time with a good, correct tocolysis. Sometimes we cannot do that because there are contraindications of the tocolysis, but we can give the corticoids. Maybe it can act only the time when the baby is there, maybe 12 hours, maybe 8 hours, we don't know, but we don't lose anything giving the corticoids. So here I have a question before finishing with the class. Does someone know what is the Ballard test? Please think aloud a little about this, and then we will show you. Well, the Ballard test is this. We will give you a paper with this. It's a little complex, but it's a kind of a score with a lot of different features that you need to check with the fetus, with the newborn, to check about the neurological status, the posture, the tone, the arm recall, the skin, lanug, a lot of different things that we need to check, and it gives a score for the baby to know the real gestational age. And with that, calculating the gestational age, we will know really if this baby is premature or not, and which was the cause of the premature labor maybe, and it's important to know it, to diagnose the gestational age. There are, I don't know much more about this, but there are some nurses of the foundation, Daniela and Catalina, and they know a lot about that. So if you see there in the hospital, you can ask to them, and she will happily explain to you more in detail. So the little golden potatoes of this presentation, the prematurity here is like the PPH for the mother. So it's the most important cause of neonatal mortality and morbidity. So the importance here is clear. We need to manage this and diagnose this very rapidly and treat it very good. The antenatal care is key to prevent and to have a correct diagnosis, because the antenatal care in the first part of the pregnancy is good to have a good scan, to have a good gestational age, and with that we can treat it correctly. Gestational age is important, believed to the fundal height, because this country, we know that have a lot of non-controlled mothers, non-antenatal care mothers, so sometimes we don't have the gestational age, we need to believe the fundal height. Corticoids save lives, and they have a lot of evidence. This is a very, very important thing. So not to give corticoids to a preterm labor, it can be penalized by law, because it's very important to know it and very important to give them. Refer the patient if you have time. If we are in a healthcare facility that doesn't have an MBU and we have a preterm baby or a preterm labor of 32 weeks, we need to calculate how many centimeters is the mother to assess how far away is the other hospital, and try to give tocolysis and send the mother to the hospital so the mother can deliver in a better place for the baby, and prepare for the resuscitation. If the delivery is imminent, she's going to deliver, we need to have all our things to prepare for a correct resuscitation. If you want to learn more about resuscitation, you can search in the seminar number 2 that we talk about neonatal resuscitation. We have a section there about premature labor resuscitation, so it's important to know about that. Thank you very much. We have finished our class of preterm labor, and we have finished our semester of seminars in the hospital. I hope you like it, and I hope this material can be in YouTube forever, so you can share with all your classmates that start the internship all the time, so it can be useful a little to survive in the hospital with the interrogation of Dr. Watau, Dr. Tati, and I hope you can become very, very good professionals that take care of the patient with love, and try to make this country, Kenya, a better country in the future. Any doubt you have, anything about any topic, or doubts about another thing, for example from Chile, or if you have a patient, you are in call, you have a problem with a patient, do not hesitate in send me a WhatsApp, send me an email. I will be in Chile, but I happily will talk with you during these 6 months. I really make a friendship with some of you, so I hope that we can continue talking. And for the other ones that never met me and are watching this video, I encourage you to be a very good interns. Make your patients like your own. Take charge of the patient like it's your patient, and try to learn with this patient. Try to search in the books, in internet, because the importance here is the motivation of the intern. If the intern is motivated to learn and want to learn, you will learn. But only put play to the video, and if you put like your face in front of the video, you will not learn. You need to really study and make an effort. So I encourage you like this. I encourage you to study all that you want and all that you need in order to have a better treatment for your patients. And good luck in the exam. See you in 2 weeks more.